afternoon, everyone. I'm Kelsey Ketchum, Senior Editor at GenomeWeb, and I'll be your moderator today. The title of today's webinar is Syphilis Update 2022, Recent Developments in Syphilis Care and Recent Syphilis Data from CDC. This event is sponsored by Diagnostics Direct. Our speaker is Jeffrey Klausner, Clinical Professor of Population and Public Health Sciences at the University of Southern California, Keck School of Medicine. You may type in a question at any time during the webinar. You can do this through the Q&A panel, which appears on the right side of the webinar presentation. If you look to the bottom tray of your window, there are a series of widgets to enhance your webinar experience. And with that, I'll turn it over to Dr. Klausner.
Hello, good morning, good afternoon. Thank you very much for joining today's webinar on a syphilis update with a focus on clinical and some epidemiology and what's new with some syphilis research and what some highlights from the CDC STI treatment guidelines. Today's webinar is sponsored by Diagnostics Direct. So over the past 24 months, I have received consultant fees from Cepheid, Abbott, Roche, Curative, and Visby Medical. Okay, well, we know that syphilis is increasing in the United States, but it is 100% preventable. There's been syphilis control programs in the United States since about 1937 with a focus on testing, early case identification, treatment, risk reduction, policy, education. However, even with a national program, early 2021 data show an increase in primary and secondary syphilis among adults. Remember, primary and secondary syphilis is infectious syphilis, and typically that means that someone has acquired syphilis in the past 1 to 6 months. In women, the number of reported cases is up about 34% to about 10,000 cases of primary and secondary syphilis. And men, there's been a continued increase since about 2008, but it's up an additional 9% based on reported cases in 2021. And what's most concerning is that syphilis in newborns continues to increase with about a 6% increase. There's been over 2,000 cases reported in 2021, and their increases have been throughout the United States, with 33 states reporting increases. So data from the CDC showed that the continued increase really has been unabated, nearly a doubling of the rate in men since 2011, and a substantial increase in women. What's important is in understanding the epidemiology, I love this CDC slide because it really shows two things. It, one, shows that males are about 5-fold increase risk for infection than females, and two is that the age distribution, the highest rates are in 20 to 40-year-olds. That tells us that this is, driven by men who have sex with men in terms of the increased number of cases. That's really the only way you can observe the disproportionate rate between males and females. But in females, it does remind us that most new cases are occurring in women of reproductive age, which is why the concern is about congenital syphilis. And when we look at congenital syphilis, as I mentioned, there's been over 2,000 infants who were born in 2021 with congenital syphilis. Anywhere from typically about a quarter of those cases may be associated with death. Some of those cases, based on the case definition, mean that the pregnant woman has not been identified or treated by the last trimester of pregnancy, And some of it also may mean that the infant was born to an untreated mother, but just has also been inadequately treated. And historically, many from the CDC and particularly Judith Wasserheit, who was the CDC director of STD prevention control in the 1990s, articulated that congenital syphilis really is a measure of failure of our public health system. Many countries around the world have been certified as having eliminated congenital syphilis. In the United States, and even in well-resourced states like California, New York State, there have been continued increases. So it really is a reminder of the deficiencies in our public health system, the inadequacies of resource allocation, funding, and investment in this important area of sexual and reproductive health. And we in the field of STDs have been, ringing the alarm bell for 10 to 15 years now. But I think it wasn't until COVID occurred that really people got to see, the old infrastructure that we have. And when I speak to policymakers about the infrastructure, I talk to them about the infrastructure about public health, but similar, what we see with infrastructure with, clean water. I mean, look what's happening in Mississippi today with, our, transportation systems in underground in Boston, our highways, and public health is really no different in terms of it requires steady investment and resources must be allocated to build a well-functioning system. And the continued cases of congenital syphilis show us our system has failed. So why is syphilis increasing? And also what's been helpful with COVID is people have started to understand a little bit about this term of the reproduction number, or R. And in STD epidemiology, we've been talking about this for a long time, that the reproduction number equals B or beta, and that's the risk of transmission between someone with infection and someone without infection. And typically for many STDs, that's about 0.5 or about 50%. And condoms are very effective barriers to reduce that likelihood of spread of infection. But as we know, particularly in some subgroups, gay men and other menosexual men who are on PrEP, condom use has decreased. Also, people living with HIV who are now fully suppressed, and because of the idea of U equals U, unlikely to transmit HIV, condom use is generally decreased as well. And then I think, we just haven't seen the type of condom promotion, condom education, condom availability programs that we saw in the 1990s and early 2000s. I always, think about when I go back and forth to South Africa and you go into the restrooms of the airports, you go into the restrooms of bars and clubs, you go into restrooms in the schools, and they have free condoms in at least every male restroom that I have been in. The second aspect about what drives STD increases and this reproduction number is what's called C, or the contact rate. So that is simply the frequency of new contacts, sexual contacts in a fixed amount of time. And that's been increasing as well. Also, I think driven in part by the successes in HIV prevention, the successes in HIV treatment, subgroups and core groups, which are important part of the population that does sustain the spread of STDs, are having more partners. There's ongoing debate about, apps and social media sites and dating sites, and whether those are really facilitating increased number of sexual contacts. On the flip side, data from the CDC surveillance program called the YRBS, Youth Risk Behavioral Study, suggests that, youth are delaying on average onset of sexual debut over the past several decades, but there are still, a substantial number of youth who report 4 or more partners in the past 12 months. And then thirdly, what's an important driver, which we in the medical field potentially can have the most impact on, is case detection and early treatment. So infectious diseases like syphilis, based on their duration of infectiousness, and for argument's sake, let's say syphilis is infections for 6 months. So if you can find someone early and get them treated after 1 month, then you've eliminated that 5-month period of continued infectiousness. But if people are not identified until much later, when they have early latent or even unknown or late latent disease, maybe 6 to 12 months or 12 months or longer, you've missed the opportunity to prevent transmission by early detection. And also early treatment and timely treatment of positive cases is a critical part of that test and treat strategy. And that was really the strategy that brought syphilis under control in the late 1940s and 1950s, and also, for that matter, gonorrhea as well. There were massive programs across the United States for case finding, for testing, for treatment, and really community-based, and very similar somewhat to the massive efforts at COVID testing. So there were a lot of pop-up sites for syphilis testing, for syphilis treatment. Public health systems recognize you didn't have to necessarily go to primary care, and the whole sexual health clinics and STD clinics in major urban areas. That's really where they got started. San Francisco City Clinic, where I was the director for about 10 years, that started in 1911. But most dedicated STD clinics supported by counties and cities really started in the late 1940s, 1950s, and we've, lost that. We've lost that infrastructure, and that contributes to a delay in case detection and a delay in treatment. So I always like to share a case with the audience, just get us thinking a little about clinically. So this was a 44-year-old man with a new lesion near his anus, reports a new partner about 2 weeks ago. And you can see the examiner's gloved fingers, and the lesion has these raised edges. The base of the lesion is not particularly red or erythematous or angry looking, and touching it, it's non-tender. And honestly, it's unlikely that the patient would even be aware that this lesion was present, because it's non-tender. It's right around the anus, and no one may have identified that. But on the physical exam by the provider, they did notice this lesion. And this would be very typical of a primary syphilitic chancre. There's rarely some other conditions that could look like this. It's not very typical of anal genital herpes or chancroid, but those might also be in the differential. And even with the current monkeypox outbreak, we're not really seeing these more excavated ulcerations. We're seeing more superficial blisters and fluid-filled blisters, or small lesions which are umbilicated. So while could be possibly monkeypox, this would be pretty typical of a primary syphilitic chancre. So under the dark field microscope, and this was a case from City Clinic in San Francisco where they still do dark field microscopy, they take a swab from the lesion, add a little bit of saline, look under the microscope, and lo and behold, you see these beautiful 122-degree angle spirochetes, which are, in this setting, diagnostic of primary syphilis and the organism Treponema pallidum. So on further evaluation, the case had an RPR, rapid plasma reagent test, reactive at 1 to 8. The confirmatory test, the Treponema pallidum particle agglutination test, was reactive as well, and I'll get into more detail about these serologic tests coming up. Diagnosed with primary syphilis, and very straightforward treatment with benzathine penicillin, 2.4 million units intramuscular injection, one and done. and then make sure that partners are notified and treated as well. So in case there's clinical individuals in the audience, I just wanted to cover some other penile chancres. These were all diagnosed, laboratory confirmed as primary syphilis, even though they look a little bit different. And I think that's the message, is that, syphilis is known as the great imitator, and there can be a lot of subtleties which can make diagnosis difficult just by clinical examination, which makes the role of diagnostic tests very important for clinicians to make a confirmatory diagnosis in this setting. So on your upper left, that's a little bit unusual. It's more redder, more red, and then you see this kind of shaggy kind of edge to it. On the upper right, these could be easily misdiagnosed as herpetic ulcers or even monkeypox ulcers currently, and these were both lesions were positive for T. pallidum DNA, and in patients HIV infected, we tend to see more multiple lesions than single lesions. Your lower left, this is actually a pretty typical lesion and pretty typical location under the foreskin at what's called the coronal sulcus of the penis. And then on your right, you see these very small kind of lesions around the meatus, but these were also syphilitic. And then these are just some additional lesions around the penis and then around the anus. So then typically what will happen is the patient may or may not notice those primary lesions. Those lesions will go away. They will resolve on their own after a couple weeks. And then they think, okay, in the clear, whatever that was is gone. I don't have to worry about things anymore. And then about maybe 8 to 12 weeks later, they may start feeling ill. They may develop a fever, some swollen glands, feel fatigued, and they'll have a rash. And they'll have this kind of reddish rash on the trunk and on the back. Sometimes it can look a little bit more like a allergic rash on the right, where the red spots kind of come together and form what's called the confluent rash. But if the doctor, urgent care, or primary care provider doesn't ask a sexual history, this would be completely misdiagnosed as, another kind of viral infection, pityriasis rosea, allergic reaction, potentially contact dermatitis. And that's why we're always trying to teach and recommend that clinicians are always asking patients about recent sexual activity, because this is a great opportunity to use your diagnostic blood tests, which are very sensitive and accurate in secondary stage, to make a diagnosis of secondary syphilis. And then some other rashes associated with secondary syphilis. You can see some kind of subtle red, a little bit raised lesions on the thigh and on the arm. And these can also nowadays, be easily similar to disseminated monkeypox lesions. And then these are some palmar plantar lesions. Also, monkeypox can occur on the palms and soles. I used to teach it was only Rocky Mountain spotted fever rashes that occurred on the palms and soles, but now we see that in monkeypox as well. But classically, and these are a little bit more copper-colored lesions, we sometimes call nickel dime lesions, that's about their size. The little concentric areas around them are pretty characteristic of a syphilitic secondary rash. And then these are just other lesions associated with secondary syphilis. So this split papule around the lip could easily be confused with angular cheilitis or a fungal infection. Also with herpes labialis, which is a viral infection from HSV type 1. Also with staph infection associated with shaving or irritation. So it's important that syphilis, particularly secondary syphilis, considered. Hair loss. I've seen plenty of patients who've complained they've had hair, on their pillow, wondering what it was. So it's important to recognize that the hair loss is secondary syphilis. And these are some what we call wet lesions or condyloma acuminata, or mucus patches around the anus or tongue. And these are particularly particularly infectious. So these wet lesions are, as they say in the book, teeming with organisms and can easily spread infection. So then after the secondary stage, we move to the latent stage, and classically there's no symptoms. So it's in this setting that we see the use of diagnostic tests, because the patient will not have any clinical findings, will have no symptoms. And that's why there's nothing to show you on this slide. So I just want to cover the syphilis test, as this is a good area to kind of review and remind folks. So we kind of break up syphilis testing into what we call non-treponemal tests. So these aren't antibody tests to the treponeme or the organism. These are antibody tests to what's called a cardiolipin lecithin phospholipid antibody, which is essentially the antibody that was discovered in the early 1900s. So this is a test that really has not had substantial improvement since, I think it's 1903 with the Wassermann test. Now this is the test that the titer goes up and down over time. Clinicians consider a fourfold change from a titer 1 to 2 to 1 to 8, or a titer down, decrease from 1 to 64 to 1 to 16 as clinically significant. It does have a high specificity. 98% is considered a high specificity, but occasionally there may be a false positive test in injection drug users or people with autoimmune disease. And then we have the treponemal test, and this is actually where there's been some advances, at least in the methods of treponemal antibody test detection over the past several years. So historically, we had a fluorescent treponemal antibody absorption test, the treponemal pallidum particle agglutination test, EIA tests, which now allow for high throughput testing in large commercial laboratories, and then very importantly, a rapid point-of-care treponemal pallidum test, or rapid TP test. And I'll get into a little bit more detail about the rapid TP test, because that's really an innovation that allows us to bring testing out into the community and get people with syphilis detected faster. So traditionally, this treponemal test actually is a bit more sensitive than the RPR, VITAREL, or non-treponemal test. So in a clinical case where you're really concerned about syphilis, you want to make sure both tests are ordered, a non-treponemal and a treponemal test. However, this is the test, the antibody, that tends to stay positive for life. So unless someone is treated very early in infection, when they might lose this treponemal antibody test, most people who have been treated for syphilis or have had a history of syphilis will carry these antibodies for the rest of their life. And that's why, just on the basis of this test being positive, it's really hard to discern, is this a past infection or a current infection? And testing, since 1937, was recognized as the foundation for syphilis control. So it was about finding cases through routine testing historically, and actually I think until the late, maybe 2012, in Oklahoma, it was still required to undergo syphilis testing before marriage. And syphilis testing is still offered in many detention settings. Syphilis testing is also required now by law in many states for pregnant women. But syphilis testing is really critical foundation for syphilis control. After testing, a key component is to notify and trace contacts. We've spent a lot of time trying to improve contact notification, particularly around COVID, and then treatment. And it's that test and treat strategy. So what's new is this rapid point-of-care syphilis test called the Syphilis Health Check. You can see it's a pretty simple system. It's a lateral flow device. It's a transfer pipette, and it's a small tube of buffer collection. I guess actually what's missing from this image is a lancet, because the finger has to be pricked, so a amount of blood can be put into that arrow, and then a drop of the diluent or the buffer And then, just like the rapid home COVID test now, this rapid lateral flow will quickly tell the provider or the user in 10 to 15 minutes if there's any evidence of treponemal antibodies. And this test is developed with 3 different recombinant antigens, treponemal 15, 17, and 44, and it detects both IgM and IgG antibodies, which actually makes it a bit more sensitive. And then importantly, there's a control line. So if there's not enough or the device isn't flowing correctly, the control line will not work. So this treponemal antibody detection assay is highly specific to treponemal pallidum. Again, as I mentioned, the treponemal antibody rises earlier but stays reactive, and you can't distinguish between prior and current infection. Colleagues of mine and myself, we did, at the behest of the American Public Health Laboratory Association, sponsored by the CDC, a systemic review and meta-analysis of rapid point of care syphilis treponemal antibody test. Now, there was actually only one test, so this systemic review was fairly straightforward. The syphilis health check is the only test that's cleared by the FDA, and we actually found, depending on the type of evaluation, whether it was a laboratory evaluation or prospective evaluation, that the clinical sensitivity was very good, and particularly, when it was combined with non-treponemal testing, the sensitivity improved to 97%. So we feel confident that this is a good assay for use in clinical and public health settings. So in summary, the syphilis health check, it's FDA cleared, it's CLIA waived, rapid treponemal test. Test performance is very good, but you have to think about, of course, like with any rapid test or any testing strategy, how you're going to use it in what population. So in young sexually active adults who may be at risk for syphilis, men who have sex with men, and pregnant women, it works very well in those who have no history of syphilis and no history of syphilis treatment. Remember, you're using a test to detect antibody, which may pick up people with previous infection or treatment. So if someone's been previously infected or treatment, it's really not going to give you a lot of information. But if someone who's never been treated, a positive test, depending on the setting, could easily turn into immediate treatment or further evaluation with RPR testing, or a combination of immediate treatment, RPR testing, and then depending on that RPR result, further treatment or not. We use this assay in a very large NIH-funded study called the Adolescent Trials Network, which was a study in Los Angeles and New Orleans, Louisiana, to look at prevalence and prevention interventions in unhoused adolescents and adolescents with a history of mental health or substance use issues. And we found about a 1.6 to 7% positivity among these high-risk adults. And this, it was easy to train research staff to use the assay, and use the assay resulted in a number of individuals who had previously been undetected that went on to treatment. So I want to move there to the CDC treatment guidelines and cover what's new and different from 2021 guidelines to the prior guidelines, which was essentially 2015. So treatment really has not changed. Penicillin G it remains the recommended treatment. We know that in private setting, penicillin G is expensive, may be hard to come by. Often it's sold in minimum packets of 10, and depending on how it's purchased, may cost up to $350 per dose. So that's a big ask, and that's a big problem that private providers are asked to buy, packets of 10, keep it in the refrigerator, and they may not use it that regularly. So that's been a big challenge in terms of trying to make sure that private providers have adequate Vicillin on hand to do treatment. And what what the results in is that prior providers refer to public STD clinics or community-based organizations who may not be open, may not be available, may have long waiting times, and provides a big gap in our ability to get people treated quickly. There are CDC recommended alternative regimens, which include doxycycline, oral medication, tablets or capsules, 100 twice a day for 14 days for early syphilis, and or ceftriaxone injection. But, a daily injection is not going to have a lot of advantages over penicillin unless, you're dealing with a penicillin allergic patient. So what is different is there are new time points for serologic response. So this underwent a lot of discussion. The prior time points were somewhat vague, 6 to 12 months. It varied by HIV infection status, 12 to 24 months for later disease, also varied by HIV infection status. And the group felt that, let's just make it clear, let's make it consistent. The time point to assess for an adequate serologic response is now 12 months for early syphilis and 24 months for late syphilis. But that also means that we have to be patient. So, while we do recommend bringing patients back at 3, 6, and 12 months, you're not going to really change management based on a 3 or 6 month titer unless that titer is rapidly increasing, which does suggest early treatment failure. So it's really about the 12 and 24 month titer where we look for our serologic response. And an important clinical pearl is that serologic response has to be based on the titer on the day of treatment. So many providers will get a screening titer, bring someone back in a week or two later for treatment. You need to get another titer on the day of treatment because a lot of cases will have a change in titer between that screening titer and the titer on the day of treatment. And that can affect greatly how you interpret their success at therapy. Then in terms of neurological and ocular syphilis, there's been a reduction in what's recommended for lumbar puncture, so fewer indications for lumbar puncture. So it's now more focused on lumbar puncture or CSF evaluation in patients with clinical signs. In patients who only have ocular syphilis or otosyphilis of hearing, no CSF evaluation is necessary because it was determined that was not going to change clinical management. And then lastly, no need for repeat spinal fluid examination at 6 months if there's been adequate RPR response in either uninfected or in HIV-infected individuals. So screening for syphilis and pregnancy. So remember, I showed you the data on the continued steady increase in congenital syphilis and syphilis in women of reproductive age. And in at least my state in California, there's been new laws which were passed saying that screening is not only recommended, but it's mandated at before 28 weeks and at delivery. Some states it's at 28 weeks or first antenatal care visit, third trimester, and at delivery. And it's very important that all antenatal care programs, prenatal care, have systems in place where they're making sure that pregnant women are being regularly tested and the test results have a plan for action in terms of follow-up. Risk factors from a variety of studies, which I've done and others have done, show that for women, maternal syphilis risk factors include multiple partners, sex or substance use, transactional sex, absence or no prenatal care, other substance use, corrections, interactions, and unstable housing. So, not necessarily surprising that this is the vulnerable population, the population that is not getting consistent prenatal care. But if people are taking care of individuals with this risk factor, they need to have, their kind of lights on and make sure they're, adequately monitoring and testing and managing syphilis. So I'm just going to end with a couple of highlights in preclinical research and then clinical research, and then I see there's been some questions, and I'll cover some of those questions. So what's new in preclinical research is actually not much, but there is a nice recent review from a couple weeks ago on syphilis vaccine development. And, in order for us to really get a handle on syphilis in the United States and globally, most experts believe we really need a vaccine. Unfortunately, investment in syphilis vaccine development has been quite modest. The NIH does support a couple research programs. I do lead one of them in Peru, and there are programs in Canada and at the University of Washington, which has a very famous one, and also at the University of Connecticut and University of Texas. But, the amount of investment is actually quite small for, the extent of research that is needed. So there's been no vaccine, really since the, clear identification of the organism and syphilis as a bacterial disease in 1912. There is a big focus now on these T. pallidum outer membrane proteins. So the challenge, unlike some other bacteria, is that these outer membrane proteins kind of cycle through being expressed and non-expressed and being on the outside of the membrane and submembrane. But researchers are really trying to hone in on which specific outer membrane proteins are important for developing some kind of immune response. It is pretty well recognized that patients who get syphilis repeatedly have a different clinical syndrome. They're much less likely to have clinical lesions or lesions that last a long time. So there is something that happens immunologically upon representation to the host where they tend to clear the new infection a little bit faster. It doesn't prevent them from getting infected, but it does either abrogate or reduce the duration of clinical findings. And so one idea is if we can replicate that immune response to people who have repeated syphilis, maybe we can come up with a vaccine that wouldn't necessarily be sterilizing in terms of preventing infection, but maybe it would prevent disease. And if we could prevent disease, we might be able to prevent subsequent spread of infection. There's been studies in rabbits from a bunch of different investigators that show some of these outer membrane proteins provide some partial immunity, but not complete immunity to infection. And then the two kind of, really more exciting areas in terms of both diagnostics and vaccine development are, based on current molecular biotechnology, the development of these large arrays. So we can put over 1,000 different proteins on a very tiny, silica array, and then we can subject different patients' blood specimens to these arrays. So naive patients, newly infected patients, repeatedly infected patients, and then we can look at these arrays and see where there's signal, what proteins are lighting up in these different disease states. So we've been doing some of that work with folks at the University of Washington and with antigen discovery. And then the last big piece is omics, and we're in this omics revolution where there be proteomics, transcriptomics, and there's novel ways really to look deeply into blood specimens and into the pathogen to see what the pathogen is expressing, to see what the host is expressing in terms of RNA transcripts, in terms of proteins. But for syphilis right now, that's really in its very early stages. And honestly, it's going to be likely to remain early unless there's some really new investment in this area. So in terms of new clinical research, and I'll end there. We had looked at a medication called Syphilis. So Syphilis is an oral third-generation cephalosporin. Its equivalent is essentially ceftriaxone by injection. It's been used in the treatment of gonorrhea. And we want to see if this cephalosporin, which is, as I said, like ceftriaxone, effective in early syphilis. We did a small pilot trial of 15 individuals, and 13 of those 15 were successfully treated. Now this pilot study has grown into 2 large randomized controlled trials, one supported by the WHO in Brazil among women, and then one supported by the NIH in the state of California and in Florida. And both those studies are ongoing. They look promising, but stay tuned for those results. And then about 2 weeks ago or 3 weeks ago, major news at the International AIDS Conference in Montreal, where researchers from University of Washington and UCSF showed that antibiotics or doxycycline after sex could substantially reduce the risk of new syphilis, what we call doxycycline PrEP or PEP. And Bob Bolin and I at the Los Angeles Gay and Lesbian Center had done this pilot study back in 2012-13, where we actually showed that patients taking doxycycline every day for 48 weeks had a substantial reduction in syphilis and in any STD when you included chlamydia as well. And adherence in these 15 men was actually pretty good. This study was replicated by Jean Molina in Paris, who looked at a different strategy called on-demand PEP, or post-exposure prevention, where he advised study participants to take 200 milligrams of doxycycline about 24 hours after sex, up to 3 days. And you can see in this hazard curve a 73% reduction in syphilis incidence, which is very similar to the 76% reduction we found in our pilot study. And then finally, in the University of Washington, UCSF, NIH-funded trial, they actually showed reductions in 3 different bacterial STIs, gonorrhea, chlamydia, and syphilis. Interesting in syphilis, among people living with HIV, PLWH, a 73% reduction. So that really, that effect size is being consistently replicated. And then in patients on PrEP, about an 87% reduction in syphilis among those who were using doxycycline. So right now, doxycycline is being considered by WHO. It's already actually in a couple of WHO documents as something to consider for syphilis and chlamydial prophylaxis, and the CDC is developing recommendations which we're hoping will come out by the end of this calendar year. But doxycycline really offers a new tool, a new strategy to prevent syphilis in those who are at particularly increased risk. And in my own practice, I discuss it with patients who've had syphilis at least once and who want to consider this as a prevention strategy. So in summary, syphilis is on the increase. There's a new rapid point-of-care assay which allows for rapid diagnosis and treatment. Treatment of choice remains benzathine, penicillin G, and doxycycline, either PrEP on every day or PEP after sex prophylaxis is infected. Some additional resources, the CDC STD treatment guidelines are the go-to place for clinicians managing patients with STDs. And then, I'll make a pitch for our textbook called Current Sexually Transmitted Diseases. So thank you very much for your attention. I think we're open for questions. So I'm going to turn it back to the moderator.
Yep, thanks. As a reminder to the webinar participants, if you have a question, please type it into the Q&A box in the control panel. We'd also like to ask attendees to take a moment after the webinar has ended to take our exit survey to give us your feedback. So let's start. The first question is, how often, if ever, do syphilitic lesions present in areas other than the genital areas?
So, the syphilitic lesion, a primary lesion, will occur at the, point of inoculation. So, primary lesion chancres can occur in the back of the throat. They can occur, around the anus and rectal area. They can occur around the labia or in the vagina. Rarely they can occur on the hand. So historically, there were reports of physicians and nurses before universal precautions, the routine use of gloves in clinical care, who would develop lesions there. And then the secondary lesions, which remember are after the organism has gone in the bloodstream and then has disseminated, these secondary lesions can essentially appear anywhere. So there's a difference in terms of the localization if you're thinking about primary or secondary syphilis.
Okay. Related to the secondary syphilis, how is the trunk rash presentation diagnosed? Is it only via blood test?
Yeah, I mean, you really only have, well, I mean, let's see. So you could have a clinical history, right? So someone could say, well, my partner was treated, for syphilis a couple months ago. Now they're presenting with a rash and adenopathy. I mean, that would certainly raise the suspicion of syphilis and might prompt a astute clinician to make a diagnosis and treat right then and there. But the blood tests are going to be, either diagnostic or what we might call confirmatory. So most clinicians will certainly obtain a blood test in that scenario. And what's reassuring is that in secondary syphilis, the blood tests are highly accurate. So, early on in the AIDS epidemic, there were, fewer than a handful of case reports of seronegative secondary syphilis, but that really never played out, and the blood tests are highly accurate. Now, rarely, a patient like that goes to a dermatologist, they're going to get a biopsy, and rarely the diagnosis can be made on biopsy. But there are special silver stains, and there's also PCR that can be done on tissue. That would be another way to make a confirmatory diagnosis.
Mm-hmm. Well, there's a couple questions actually on molecular detection. So one, I'll combine them. Is there a clinical reason that genital specimens are not used for molecular detection? Is there a strong reason for the diagnostics being predominated by protein detection versus nucleic acid? And then somebody else asked whether there are any molecular testing options for syphilis.
Yeah, so most of the large commercial laboratories do have laboratory-developed tests for molecular diagnostics for T. pallidum. Some of those are multiplex, so they may be T. pallidum, herpes simplex virus type 1, herpes simplex virus type 2. Some of them have a quadplex with varicella zoster virus in there, because those would be the four kind of typical organisms that one might be considering with, genital or skin lesions. But the problem is, because they're LDTs, that they're not marketed. So most clinicians and programs don't really know about them. So the cognoscenti, and we teach about them, but there's not a lot of uptake of them. And then, they have to be used on a lesion. So many people will present with syphilis in a latent stage, either between primary and secondary or after secondary. They may not have any, lesions. And it works much better in mucosal lesions associated with primary or mucosal lesions associated with secondary than the dry skin lesions, right? It doesn't really work that well on the dry skin lesions. And those dry skin lesions are for that reason also considered non-infectious. So it's the wet lesions in secondary or the primary chancres that are infectious. Now, we've also been doing studies looking at, just somewhat blind screening in oral mucosal specimens or rectal mucosal specimens. And investigators have shown about maybe 50% of the time, you actually can find evidence of shedding T. pallidum DNA in these mucosal sites. But, that really hasn't launched into prime time screening or, a prime time adjuvant to make a clinical diagnosis.
Mm-hmm. Are there new point of care diagnostics that you wish were available for syphilis, or even multi-pathogen point of care tests, for chlamydia and gonorrhea and syphilis combined?
Well, I think when we think about, STIs, we kind of end up splitting them off in between like diseases that cause, urethral, urogenital, vaginal discharge. We call it discharge diseases like chlamydia, gonorrhea, trichomonas, even mycoplasma, then versus diseases that cause ulcers or genital ulcers, which we call genital ulcer diseases. For those genital ulcer diseases, clinicians would love to have point of care rapid molecular diagnostics, right? So they can take a swab of someone who presents with abnormal genital lesion, and they can, in 30 minutes know, okay, is this varicella zoster? Is this herpes simplex type 1? Is this herpes simplex type 2? Is this T. pallidum? And that quadplex would be very useful to provide, much more rapid detection of these different pathogens, which could reduce empiric treatment, which would reduce the overuse of antibiotics or over antivirals. It would also facilitate, public health efforts to control the spread of infection by identifying and treating people early, correctly, and then facilitate getting their partners in. I mean, without a doubt, we do lose people in, clinical care settings. People come in, they don't come back. We can't get the test results communicated to them in a timely fashion. So having point-of-care molecular diagnostics would be very, very helpful.
Mm-hmm. With somebody else also wanted to follow up on the molecular side and see, aside from the lesions, can blood be used for molecular testing for this, and how does the performance compare across sample type?
Yeah, I mean, so we and others have done, blood studies to look for T. pallidum DNA detection in plasma, and it works okay. So the period of spirochemia, or it's called DNA-emia, seems to be not that prolonged. We don't truly know how long. We think we know after primary chancre. There's bloodstream dissemination for days to weeks, and then in secondary disease there may not be any real spirochemia or DNA-emia. The studies anywhere from 25 to 50% will detect DNA in people with early syphilis, primary or secondary. We've actually found about maybe 10 to 20% in individuals with early latent as well. So it can be detected. Now, arguably our detection, at least the ones I'm using, are real-time PCR, which is not nearly as sensitive as other potential cell-based DNA detection assays. I'm thinking of some other commercial products that have a very, very low limit of detection and can really trace amounts of DNA in a clinical specimen. And I have not seen any research using those more ultra-sensitive techniques.
Mm-hmm. For a quadplex test for STIs in general, a couple people have asked, would you add monkeypox to a quadplex test like that at this point?
I mean, today, yes. In 2 months, maybe. The trajectory of the epidemics are now on the downslope in every major urban areas, but that doesn't mean it's going to go away. So, there'll probably be some ongoing, continued spread at a, endemic level, but not, in this kind of hyper-endemic kind of epidemic phase. And that's certainly going to continue to be in the differential, from now forward for patients presenting, to sexual health and reproductive health clinics with lesions. So, I know lots of different folks are also working on alternative specimen types, whether it be saliva or rectal specimens. But, I think, having a monkeypox target, yes, would make sense.
Mm-hmm. Okay. Moving to some of the rapid syphilis tests, one person wanted to know who might actually use a rapid syphilis test. Would it be primary care doctors, or only doctors or places of care that see patients with high risk of loss to follow up? And then what are the advantages of a rapid test? Kind of combine those.
Yeah, so I mean, we've seen the greatest uptake of rapid syphilis testing, particularly in public health settings, and also in outreach settings where people are working with community-based organizations. But we've also seen uptake in urgent care and in some primary care settings where either from a marketing perspective, they want to promote, we have rapid diagnostics, we can make a diagnosis now, or, just for improved patient care. So, people can have a result and then they can have their result managed on the, same day, potentially at the same visit. So, particularly in someone who, has no history of syphilis or syphilis treatment, a new rapid syphilis test does trigger, strong consideration for immediate treatment and additional testing to, determine what the titer is. I mean, many people believe, no one should, go through life without the opportunity to be treated for syphilis if you've had a positive syphilis test. So I get a lot of consults, on older people who've never been treated, and you kind of have to say, well, the treatment is safe, it might be effective and useful in this person, treat them. And then, it's, useful in places where there's a delayed turnaround time, or, it also reduces the staff effort, right, to have to follow up. So depending on their patient population and their frequency of positive tests and the amount of staff time they're investing in follow-up and callbacks and rescheduling, having rapid point-of-care diagnostics can really increase the efficiency and, the effectiveness of the workflow.
Mm-hmm. Okay. For the rapid test for syphilis, someone wants to know what your experience has been with reimbursement for those kinds of tests.
I think I'd have to defer to others on that. So I'm either in public or university practice, and I'm in the fortunate space of being behind the curtain on reimbursement.
Okay. That's totally fine. Are there any specific diagnostic issues for maternal or newborn testing?
Well, the tests work well. I mean, there was this kind of canard for many years, that pregnant women would have an increased rate of false positives, and either we shouldn't test them or we should discount the result. I mean, that really hasn't held up. I mean, a positive test in a pregnant woman needs to be taken seriously. And if they've been untreated, they need to be treated. I mean, the two-step algorithm, the traditional one of a screening test and a confirmatory test works well, or the reverse algorithm of a treponema test followed by an RPR test is another way to do it. But, in pregnant women, need to take the test results seriously and, err on the side of treatment, given the new laws and the, increased requirement for documentation of testing. I mean, doing rapid testing is an easy way to make sure that those tests get done. And, in labor and delivery, there's plenty of opportunities to do rapid testing, plenty of specimen could be available. And some hospitals, public hospitals I used to work at, will not discharge a woman, after delivery unless there's a documented syphilis test on the medical record. That's going to vary potentially from system to system and hospital to hospital, but a rapid test in that way, would be an easy way to have a documented test result and allow the woman to go home.
Mm-hmm. Going to the doxy research that you mentioned, there's a couple questions on potential for increasing drug resistance and antibiotic resistance. Are there any thoughts that you have on that or any?
Yeah, certainly, the issue of antimicrobial resistance, AMR, has been a, big topic, perhaps not as big as climate change, but, it's up there as like the big existential threats to humanity. And the good news is that, since the advent of tetracycline, doxycycline in the 1950s, there really has not been any resistance developed in syphilis or T. pallidum or chlamydia trachomatis. Yes, there's this case report of chlamydia suis in, swine or pigs, but there just hasn't been any concern in those two pathogens. In Neisseria gonorrhea, yes, about 30% of gonorrhea in the United States is tetracycline resistant. So it's not a recommended drug for gonorrhea anyway. The concern also has been, in either commensals like Staph aureus and colonization of staph, how it would affect staph, and in, the microbiome in the GI tract and how it might affect that. And, we remind people that, monocycline, doxycycline, tetracyclines are widely used in, dermatology for the management of acne. They're also used as prophylaxis for malaria. They're also used for prophylaxis for Lyme disease. So, it's a little bit of a risk-benefit discussion, but we think now, as our tools for control of syphilis are so limited, that the benefit does outweigh the risk. And if we have a vaccine in 10 years, maybe we'll be able to drop the strategy. But again, it's not for everyone. It's for really a core group of people at substantial increased risk. And the doxy-pep, the 200 milligrams once, does reduce exposure versus 100 milligrams once a day.
Mm-hmm. Are there any other knowledge gaps in the doxy treatment, or any areas?
Well, I think there's still, we did a survey in Palm Springs among providers, and most providers had not heard of it. They were hearing about it from their patients. So the community, does have some awareness of it, but there's some gaps in terms of what providers might need to know. And then there are some gaps around the effect of the microbiome. And in the UCSF University of Washington study, and there are studies in France and in Canada and in Australia, they're looking at that. So they're looking at some of the effects of resistance and what we call the resistome on the effect of increased exposure to doxycycline.
Mm-hmm. Okay, I think that's all we have time for. So we'd like to thank Dr. Klausner and our sponsor, Diagnostics Direct. If we didn't have time to get to your question, we'll try to follow up with our expert. And as a reminder, please look out for the survey after you log out to provide your feedback. If you missed any part of the webinar, want to listen to it again, an archived version will be emailed to everybody. Thanks for joining us for this Genome webinar.
Thank you for your attention and participation.